Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, your host for today. Our topic is the 2021 final rule and the end of web interface, how to prepare your organization. Before we get started, we've got a few things we want to just go over logistically and introduce you to Mingle Health here briefly. Here at Mingle Health, we're proud to be your partner in the transition to value-based care. We pride ourselves in helping organizations improve what matters, saving time, improving quality scores and outcomes, and increasing earnings, especially from these value-based programs where organizations are increasingly being encouraged to take on risk. We'd like to thank all of our clients, partners, and the frontline healthcare workers who are helping respond to the COVID-19 pandemic. It's been an unprecedented time, and we really thank you for your service. Some housekeeping items before we go ahead and get started here. This webinar will be recorded. The slides and recording are going to be distributed by email later this week. We've got experts on the line that we're going to hear from shortly here in the presentation, but we've saved plenty of time to answer your questions. So please submit questions throughout the webinar, and we've saved plenty of time at the end to go ahead and dive into anything that you send our way. And if we can't answer them, then we'll be following up as soon as we can. Research those questions. Some items to be on the lookout for. March 31st is the end or the deadline for the qualified registry submissions for the 2020 performance year. So if your organization is submitting, please go ahead and make sure you are on track to do that. Our team is going to be looking ahead to 2021. So we have a webinar coming up next week as well, if that's something that you're interested in. And we are really excited about the Primary Care First program. Like I said, we are your value-based care partner, and we've been working with MIPS for a really long time, but also other APMs or alternative payment models. And Primary Care First is a very exciting program that increases capitation to primary care practices and gives them room to innovate. And we've been really successful in helping folks increase their patient attribution and get started with that program. The next cohort, actually the deadline, the applications are going to be opening up any day now. So be on the lookout in your email for that. All right, we are ready to get on to the presentation. I'm excited to have my colleagues Jeff Yasili and Allison Casaccio with us today, who are experts with decades of experience in healthcare in many different configurations. So it's going to be a great time. Over to you guys for the presentation.
All right, thank you very much, Charles. So I am Jeff Yasili, and it is my great pleasure to introduce Allison Casaccio. Allison is our VP of Client Services and a great example of the passion and expertise for healthcare at Mingle Health. She's a registered registered nurse, board certified in nurse informatics with experience in several EHRs. She has multiple EPIC EHR certifications. She's trained in process improvement, including GE's change acceleration process, which I learned quite a while ago. And she's also done some executive coaching. Just personally, I work with Allison very, very closely, and she just has a tremendous depth of curiosity, creativity, and passion. All traits I see in her every day, and just what every organization needs in a leader. Under her guidance, our client services team, already one of the best in the business, has taken their efficient delivery of value to a new level.
Thanks so much, Jeff. So Jeff Yasili is our VP of Operations and Major Accounts. He has a 25-year-long career working in the healthcare product and service space. Tons of companies like IDX, GE, Allscripts. He's a Lean Six Sigma black belt and has really used these tools to lead our teams through the best approaches to design, measure, quality. Frankly, this has allowed us to maximize the value we bring to our clients and help everyone succeed in their quality improvement efforts. So he is also appreciated.
Allison, thank you. All right, let's take a look at our agenda. So we're going to talk today about the changes that have brought us all here, particularly the changes that precipitated through the final rule. We're going to talk about who that impacts. We're going to talk a lot about what you need to do to prepare. These are significant changes, so we want to spend a lot of time on these middle bullet points here, where we'll talk about what you need to prepare, what you need to understand about how this rule affects your organization. We'll also talk about the details about how the program works, and we'll talk a little bit about how Mingle can help you through this transition. And last and not least, as Charles had noted, we'll take your questions. We've left some room, plenty of room at the end, but please go ahead and use the question box and pop those in anytime you are ready. All right, so let's talk a little bit about what exactly has changed. So these changes are the result of the 2021 QPP final rule. Final rule is something that comes out for the program every year. It's always a cause for major excitement here at Mingle Analytics, where we jump into the 2,000-page document and tear it to shreds, trying to figure out exactly what they did based on what they talked about doing in the proposed rule. So CMS finally released this rule at the beginning of December, and then they officially publish it on the Federal Register at the end of the year. Today, we're really focused on the APM Performance Pathway, that's the APP. They revised the final rule, or the proposed rule, to allow web interface for one more year. So that is something that they were talking about eliminating this year, but they've given us one more year of web interface. You can use the APP in 2021, but you don't have to. If you're an ACO, which we expect most of you are, then you will absolutely need to use the APP, the APM Performance Pathway for reporting in 2022. So why did they do this? CMS's overall goals are to really improve quality and to reduce cost. I mean, that's what they're really trying to accomplish. And anybody that's taken a look at the federal budget knows how much we're spending on healthcare right now. So they've got a vested interest, and as taxpayers, we should have a vested interest in reducing the cost of the care that they pay for. They have a lot of programs that are all trying to do this. And as we all know, it's really, really hard. They're trying to align all of these programs, use measures that are relevant, and work broadly as they provide, so they can provide good comparisons. What were CMS's goals? They're really trying to create consistency and alignment with the MIPS value pathways. That's a major piece of the QPP program that they will be rolling out over the next couple of years. The MVP is really a topic for another conversation. The APP is required for the Medicare shared savings plans and ACOs in 2020, as I mentioned. And then just as far as identifying the ACO as a MIPS entity, the shared savings plan, like most APMs, really have their own reporting rules, their own measures and mechanisms. Under the ACO, and then under the ACO will now be under the MIPS rules. So Allison, who cares, or who should care?
So I want to talk about who's going to be impacted by these changes. Obviously, ACO leaders and managers or administrators working at any practice that's part of an ACO or APM. These leaders have a lot of pressure to show strong performance and really make measurable improvements to both their quality and cost year over year. Notice I have clinicians on this slide. That's because they're going to feel this pressure to perform as well, but in a really personal way, because whether or not it's a care issue or a documentation or process issue, low performance in a measure just feels like a direct reflection of how good of a clinician they are. So obviously, quality and population health management teams are in the mix too. We've got leaders looking to them for answers about why performance is where it is and what can be done to see continued improvement. So the same pressures exist for any organization currently using the web interface method, frankly. And we know that every organization is going to have its unique challenges. There's multiple technologies in place, change management, governance, the politics of the organization. Everyone's holding you accountable for their performance, and in the end, only results matter. So what we want to do is give you some areas where you can get laser focused, and Jeff's going to talk about that.
All right, thanks, Alison. All right, so let's start diving into the details, and boy, are there a lot of details. We'll try and move through these, try to make them, package them in a way that is easily digestible and really highlight the things that you really want to focus on. So if you're an ACO or you are involved participating in any advanced payment model, particularly in the shared savings program, then yes, the APP is just for you. Hooray. If you're an organization who's currently, a particularly large organization, who's taking advantage of the web interface mechanism, then you're going to need to transition to a MIPS submission. The APP is actually not for you, as in the change of the final rule effective in 2022, if you are not an APM, if you are not an ACO under the shared savings plan, and you are submitting under web interface, you are going to need to find a different way to submit. And that is typically through MIPS, and Mingle would be happy to talk to you more about that. We have a team of folks that will be great resources for you. Alison is going to talk in detail in just a few minutes about the changes to the measures. She'll also cover the changes to who gets measured. And with the measure changes, there comes changes in data that you'll need for reporting. I'll talk more about that. And then we'll talk a little bit about what you can expect for performance. CMS has given us insight based on the changes to benchmarks, and we'll talk more about those. But we do expect that there will probably be some reduction in performance. All really, really good reasons to know early and to be able to prepare. So before we discuss the measures, let's take a look at how the APP changes your reporting. So as an ACO and a participant in the shared savings plan, you've been reporting under the web interface. So this method requires ACOs to report performance for a sample of their attributed beneficiaries. All right. So I'm sure you're all very familiar with this, but CMS identifies 248 patients for each of the 10 measures and gives you a list of those patients. The list is actually typically longer, but you have to report for the first 248 patients on that list. So typically, this is a manual process, and once you get the patients identified, you have to go in and do what we call a chart abstraction or evaluate the patient's chart based on the requirements for the measure to determine whether the patient actually met the measure or not. And then once that work is complete, you enter it all into a spreadsheet and you upload the spreadsheet to CMS. So this method has been around for a while. It's getting a little bit long of tooth, and while there are definitely some advantages to it, it's probably time for a little bit of an update. So under APP reporting, APP uses the MIPS rules, and here at Mingle, we're very, very familiar with these rules. It means that your denominators are going to increase. So now you're reporting for all patients, and you're also going to be reporting for all payers. So where you were just looking at a sample of your Medicare beneficiaries under web interface, now you are looking for all the patients who qualify for the measures based on the measure specification and looking at all the payers, not just Medicare. So Alison, can you tell us a little bit about how the measures are changing?
Sure, absolutely. So you can see here, this is the total list of measures that used to be the focus for web interface submissions. We've got the CAP survey, 2 claims-based measures, and previously 10 quality measures. So CMS has on one hand streamlined this quite a bit. Now you're only going to be responsible for CAPs, claims measures, and 3 quality measures, the A1C port control, depression screening, and blood pressure control. Now on the other hand, Because we're moving from Medicare sampling to all patients, all payers, we'll be looking at more eligible instances to evaluate. So instead of 248 patients per measure, it's likely to be thousands. I want to go through some different ways to examine these 3 measures so you can really begin to think about what kind of challenges they may present for your specific organization and to consider ways to plan proactively about them. So let's talk about performance. The example here is of the blood pressure control measure. So often when organizations talk about these measures, they talk about them from the perspective of the title only. And depending on the method you choose, there's going to be subtle differences. CMS publishes their national average performance against each, and we've got that here in the slide. Just know it's a little bit of a lagging indicator because they do typically take a 2-year cycle to analyze those national results. Our average performance, which is all the way to the right, is what we've seen in just the organizations who are clients of Mingle, but it's a bit more recent because we're just looking at the past year. So anecdotally, if you've been using web interface, you may be expecting somewhere between 50 to 75% performance rates on this measure. You can see that both the registry and eCQM, or that EHR certified version of the measure, run a little lower, and we found that the registry version tends to see higher performance rates. Jeff actually has been talking with many of our ACOs about this very thing.
Yeah, that's a really good point, Allison. I've been fielding a lot of calls from ACOs who are trying to figure out what this change means for them. And I actually talked to a really large ACO that has actually done a sample analysis based on their current data. And interestingly enough, or maybe not that interestingly, it tracks exactly with what we're seeing here. In that their analysis or their projection is they're doing web interface right now, they're doing pretty well. Their eCQMs are doing slightly worse than that, and then their CQMs, or their registry measure, an example of that, is actually tracking in the middle. So not quite as good as web interface, and much better than the eCQM performance.
So while we're looking at performance, we can't talk about performance without looking at benchmarks and scoring. So I wanted to give another example. This time we're looking at the A1C measure. Remember that in all versions, the A1C measure is inverse. So that means the lower your performance, the better your actual quality of care is. So CMS's national average, or their mean, is going to be in the 5th decile, right? What I've circled here is the past year's average that we are seeing with our clients. So again, this is about minimizing surprises. If you expect to land in decile 8, but actually end up performing in decile 5 or lower, you may need a plan for how you're going to analyze and address this. Being able to see both the eCQM and the registry versions side by side will be helpful. Being able to understand performance differences at the provider, practice, and ACO level is going to be essential in understanding who's following those EMR workflows, who isn't, and why. Because at the end of the day, we can select for submission whichever method secures you the best score, but you're going to need to understand what's happening in order to make real improvement. So that's going to bring me to my example about documentation. And we have a slide on that too. There we go. So when clients ask, why are the eCQM benchmarks lower? Or why are the registry measures performing higher? One of the primary culprits driving this difference is documentation. So here we're looking at depression screening and follow-up. We know the patient needs screened for depression, and if you get a positive screening, our next step is to examine how that follow-up action was documented. So the examples I have here are just really common ways we've seen the clinical data come in. So if that PCP that we're talking about orders a psych referral, and there are no complications in the EMR's referral flow from one practice to another, so everybody cross your fingers, then the patient will fall into the numerator on the eCQM report, and all is well, and we move on, right? Same goes for the medication order. That's because all of those follow-up actions, if they're documented appropriately, are going to get mapped behind the scenes to things like RX norm codes, SNOMED CT codes, lots of other structured records that from the front-end user's perspective, you don't even necessarily need to know every detail of. It's the examples that fall through the cracks in that eCQM report, however, and I've put a few different examples here in the bottom 3 rows. So doctor talks to the patient. He says he's been seeing a therapist for the past 10 years. It's out of network, or it's not referred by anyone at our practices, or maybe we just have some challenges in the referral workflow. doc doesn't know how to enter a new provider into the system, or I don't have time, or they're simply just not coming up in the search that's provided in the EMR. What's that doctor going to do? They put it in their note. And the same for all these other examples, right? The clinicians don't always follow the workflows as prescribed by their EMRs. Sometimes that's for legitimate reasons, but that doesn't mean the quality of care isn't being addressed. It just means it's not being documented in a way that the reporting logic in the EMR can see it. And it's essential for you to understand why performance may be lacking, because if you fix the wrong problem, you're just going to end up with wasted effort, frustrated clinicians. So let's think again about web interface, right? We caught those details in web interface because we're doing a chart review. We've got live humans reviewing the cases, and live people can make clinical judgment calls about the data when computers can't. The registry process also involves live people. So our clinical informaticists understand and assign value to records that are otherwise overlooked. We actually use some internal tools we've built to basically pull needles from haystacks. And the registries are allowed the flexibility to do this, right? It's so we can take advantage of all your data, not just the data points that fall into that EMR's more narrow workflow. Now, if all of your clinicians aren't following that prescribed workflow every time, then the eCQMs might not be reflecting your best clinical performance. Really going to depend on your organization and organizations. So let's go back to the visual of the ACO's patient population, because there's really two key points I want you to take home from all of this. So one, you have an expanded patient population now. So because we're looking at all payers, our populations are going to expand beyond that 65 and older group. And that doesn't just impact the documentation workflow like we just discussed, but the actual clinical care interventions. How your clinicians treat a 70-year-old with diabetes is just likely to differ from their approach with an 18-year-old. And their approach really needs to be best practice and customized for that patient segment if you're going to get outstanding outcomes. Secondly, just to hit home again, the number of patients that you're looking at is going to increase. It's going to increase enough that continuing to do manual audits of your METs and not METs, it just isn't likely to be sustainable. Now, we can accommodate those who want to either undertake that work or use it to supplement, but what you're really going to need here is a technology-enabled service. So you're going to need someone who is going to turn that data into actionable information for you, while giving advice and recommendations to help you understand the difference between when you have a clinical care problem, a documentation care problem, and how that impacts your performance. Right? So, because again, what matters to your stakeholders are results. So Jeff has a few slides. He's going to talk about how this actually works and how we get the data to do this for us in the first place.
All right, data. So if your ACO has an enterprise EHR, and by enterprise EHR, I mean that all your member groups, all your participating providers are using a single instance of the EHR, then you have the option to report either registry measures or eCQM measures. Now, the rule allows for either the registry measures, also known as CQMs in the QPP language, or eCQMs, also known as EHR measures. And that's what Allison has been talking about. These are the measures that are generated based on your EHR, from your EHR, based on rules that are programmed by your vendor. And as Allison pointed out, those rules require a standard workflow for your clinicians. Otherwise, they don't really, or they may not accurately reflect your performance. So this is, if you're not on an enterprise EHR, and like in my diagram here, you see an ACO that is, I think, much more typical of the groups that I've been talking to. You're working across distributed systems. So your member practices may share some EHRs or may have their own EHRs. There are typically multiple sources. This is really a frequently asked question I'm getting from the ACOs that I'm talking to. For the APP reporting, eCQMs need to be calculated and reported in a single report. That means you need to have them on a single EHR. So in this example here, and in most of the ACOs that I'm talking to have multiple systems, eCQMs are not really a practical option for you because you can't calculate a single report from multiple EHRs. They all have to be on a single report. Luckily for Mingle, we've developed a process and tools to aggregate data from multiple sources and calculate measures that as CMS requires of their qualified registries, those results are true, accurate, and complete. So that's something that we have developed over time. And I'll talk to you a little bit more about that. One other point that I want to make, and we really haven't been talking about any of the other performance categories or how the scoring is done, but in general, quality is always the largest portion. It's actually 50% of your overall score. And it's also usually significantly more difficult to manage than any of the other performance categories. As an ACO under the shared savings plan, you don't have to report improvement activities. You actually get the full benefit of those, but you do have to report promoting interoperability. And unlike the quality measures, which I just described, can't really be aggregated from a bunch of independent reports. The promoting interoperability or the PI performance category actually can. It's relatively easy to take your promoting interoperability results from multiple EHRs and add those all together and submit those to CMS that way. So let me just talk a little bit about these challenges. So these challenges as they present under APP, the ones that I just really described, those are really challenges that Mingle has actually been built to solve. Since PQRS days, we've served the wider healthcare market from single providers to really large academic medical centers or health systems. And we've developed a really flexible system that will use a variety of data from a variety of sources. And from that, we can calculate performance. We can provide ongoing monitoring, and that provides you the opportunity to see where you're not performing or identify, as Allison was saying, maybe some of your documentation gaps. Maybe it's just a question of data, and we have the ability to work with you to identify how we can get better data or how we can fill those data gaps. And then that gives you, from a quality improvement perspective, the visibility to say, this is how I'm performing right now, this is how I want to be able to report, so being able to make whatever adjustments are necessary to improve that performance. But first and foremost, getting an idea of where you are right now, and then being able to see where your options are. If we are going to be seeing some changes based on the benchmarks that Allison just pointed out, that movement from web interface to either eCQMs or CQM measures, it would be good to know that sooner rather than later. So again, you can make those adjustments wherever those adjustments are possible. And then the last and final piece of this is not only do we give you that kind of state of the state of performance at any given point, we can provide ongoing monitoring. One of the challenges that I've heard as I'm talking to ACOs is that the web interface measures are that sampling method. So you don't know exactly who you're reporting on until CMS tells you who you're reporting on, and you usually don't get usually you never get that list of sampled patients until January. So then you have to go through this process of calculating and seeing where you end up. Under this process, you really have the opportunity to track this on an ongoing basis. It's a lot of patients, it's a lot of data, but we can help you with that. One of the other things I also just wanted to mention is in this scenario where you have multiple EHRs, one of the ACO leaders that I talked to said, I don't know how I'm going to deal with that. That's just going to be a logistical nightmare for me. If you're not collecting data in a centralized fashion right now, Mingle can absolutely help facilitate that. It's very much like the process that we use in a number of our large organizations where we work with some of the different practices, some of the different sources, or some of our partners in terms of grabbing data from the different distributed systems and aggregating that together in our platform. And then the last piece, of course, is the actual submission to CMS. We're not exactly sure how that's going to work under APP. They haven't actually published those details yet, but I expect that they will be transferring that data or allow us to transfer that data through our API. So we have an automated process once we complete a workflow where we evaluate or do that final evaluation and get your green light to submit, we can actually ship that data automatically to CMS on your behalf.
And just to throw in a little note there, one of the things that I love about that automatic API, although that's a strange sentence to say, is that we get immediate feedback from CMS on what they score. So we give you an estimate, we see the exact preliminary score that CMS gives you, and it allows us an opportunity for our consultants to follow up with clients and say, hey, here's what we expected, here's what we got, what do we think?
Right, and our estimates are actually usually pretty accurate. Not perfect, but pretty accurate. And one of the things that we do, Alison mentioned the API, is we have a test API with CMS, and we're constantly polling that throughout the year and evaluating our measures compared to what CMS is reporting, and just evaluating and identifying where there are any differences between how they're scoring and how our algorithms are matching those or not matching those. And we make adjustments on our side when appropriate, and other times we actually are in communication with CMS and saying, your results don't seem to actually jibe with the measure specifications or the scoring rules. Can you check into that? And they have changed them in the past. So let's talk a little bit about what you could expect from Mingle Health and how we can help you through this transition. Alison?
Sure. So in my opinion, one of the big things that sets Mingle Health apart from other registries you could select is our consultant team. You're going to have a dedicated expert consultant assigned to you. Their focus is on your goal setting, your unique challenges, and your success. So we use a standardized project plan with clear target dates throughout the year that really helps simplify the project for our client and helps them succeed. The consultant also brings a national perspective to your table. So they can tell you how other similar organizations have handled the problem or problems you're facing in the moment. And because they're assigned to you, they're available for questions, subject matter expertise, and even, frankly, as a digital colleague in your pocket if you need someone to just bounce improvement thoughts and ideas against. Jeff, you want to talk to us about data from a Mingle perspective, since that's been your
Oh,
focus?
I've talked so much about data. No, yes, yeah, I just want to really recap here that I think it's really key. Again, you may already have all of your member practices, all of your providers on a single system, and that's great. What Alison had pointed out, though, with the benchmarks is your performance may vary. It would be great to know how you're performing on those, on both the eCQMs and CQMs if you're on a single system. And there's no reason why you can't report a mix of those measures to get the best possible performance and the best possible score. So something to look at if you're on a single EHR. If you're on multiple EHRs, you got a challenge, and we can really help there. Besides the general benefits of, I think, reporting under those registry measures, under the CQMs, the ability to provide data, to evaluate that data, to actually drill down deep on that and be able to identify where your gaps are or where better sources of more complete information are all things that we can do through our process. I also wanted to, again, just mention, and Alison had really hit this point before, is that with our clinical informatics team, we can evaluate your clinical data, and we're not subject to those strict standard workflows that an EHR has programmed into your system. So if you haven't been looking at your eCQM measures as they come out of the EHR, as they're reporting at the EHR, you may be in for a surprise there. And we can certainly help with that. We can provide some consulting around your eCQM measures. And again, this idea is that with the flexibility that we've built into our system, both from a consulting or service perspective, but also from a technology perspective, this gives you a lot of flexibility to really kind of drive towards the best possible scores at the lowest possible effort on your part.
Sounds good. Also, although the APP is certainly going to have you focus on these 3 quality measures, there are as many as 47 measures that an EHR can be certified in, and our registry can track up to 232 different measures. So I think why that's useful is it helps you align your practices, any additional internal quality work they may be doing, with some real analytics and real measurements of what matters. In addition, because CMS has now allowed ACOs or the APM entities to be considered a MIP submission type, which we talked about in the beginning, this means that if you have practices with lots of specialty clinicians, we could also do a traditional MIP submission for individuals or groups in addition to that APP submission. I don't want to fall down a giant rabbit hole here, but the benefit is that in many cases, clinicians join ACOs for the higher score. So if we do an APP submission and an additional MIP submission for the practice, although CMS is absolutely going to use your APP scores for MSSP, they'll take the higher of the APP and MIP submissions to apply to those NPIs on the MIP side of the house. So basically, we can help you decide, is it in your best interest to do these additional submissions, walk you through the process, and just ensure you get the best scores that not only get you good financial turnaround, but keep your member clinicians happy and engaged.
And that process goes double, really, for these organizations. Anyone who happens to be attending here that is not part of an ACO shared savings plan. If you're reporting under web interface now, that option is going away for you. You can still do that for 2021, but in 2022, you're going to need to do something different. Mingle would be very happy to talk to you about what your options are there and help guide you through that decision and just give you some of the options.
And just as an FYI, I think Charles actually has a poll for us. Since we've gone through some of our challenges, we've talked through some of these things, we're really interested to hear, what do you anticipate being your biggest challenge?
All right, go ahead and I'm launching that poll now. So if everyone could take a moment, you should be able to select multiple options here, because we understand there's so many facets to this across the different organizations and ACOs. So we'll take about 30 more seconds. Jeff, Allison, thank you so much for diving into what folks need to be aware of in this transition and all the different pieces and how they fit together, and really making it pretty tangible for folks. So hopefully they've got some ideas of where their head needs to be at. I also want to thank everyone for joining us. We've got a couple questions that came in here that we're ready to jump to just as soon as we close the poll. But please do, once you've responded, go ahead and take a moment to get your questions in, so we make sure we get to as many as possible here in the time remaining. All right, we'll do about 10 more seconds. All right, thank you. And we'll just go ahead and for all of you to share those results back quickly. Hopefully you all can see that on your screen. Jeff and Allison, are you seeing that as well?
I am trying to figure out how to see that.
Okay, good. So it looks like our top pieces are risk of reduction in quality scores, documentation and workflow variability, with several of the other elements coming right up there, combining data from multiple EHRs being up there as well. So thank you so much for sharing that feedback with us. It's great to kind of get that live information of what's on your mind after hearing the presentation. All right, so let's go ahead and dive into some questions. So we're going to get to as many as we can today. But Jeff's got up on the screen here as well. We've got a wealth of resources on our website. We also have live chat and our web form and a call. Allison's team actually answers the majority, when you call in, answers the majority of those calls. So it's something we're really proud of, is you get to talk to an expert really at the end of the lines there. All right, so our first question is from Carol. If hospitals are unable to aggregate data across multiple systems to report eCQMs for the APP, is there any advantage to reporting the quality data that you can, even if it's under the 70% threshold? Would some data, particularly if bonus points, prevent a 0 in the quality score for the participating TIN if reported through the ACO? So that's a great question. It's really the heart of the matter here. So one, bringing the data together, but then, reporting what you can, but not reaching that 70% threshold. So Allison.
I actually think I'm going to let Jeff take some of this. One of the things that I want to remind everyone that when we're talking about that 70% threshold, it's 70% of your numerator. So in order to understand 70% of your numerator, you have to understand 100% of your denominator. So that's just a piece to keep in mind, especially when moving from that sampling methodology. I think it's a piece that needs to, it just helps to clarify.
Yeah, that's a really good point, Allison. And I hear a lot of questions about this, and there's a lot of, I think, just general misunderstanding. CMS is very, very clear. We as vendors have to attend monthly meetings with CMS about the qualified registry and QCDR and their rules. And this question invariably comes up every single month. And CMS is always very adamant that that 70% rule or that 70% requirement for reporting is an accommodation for a recognition that you can't get data for every single patient or every single visit. They're very, very clear, and they have said they will come down very hard on registries and the folks that are reporting through them if they find that folks are using that to take advantage and to cherry pick data. To Allison's point, it's really clear, and this is a big shift moving from this sampling method to a full patient, full population measurement, is you need to report on all of your patients. The 70% is just on the numerator side of things. So CMS is giving you a little bit of leeway of saying, help us, give us a little bit of a break because we can't get performance for every single one of our patients. That is the reporting rate. So we still need to report on 100% of your patients. So if you don't have access to 100% of your patients, we need to figure out a way of helping you get there, or not reporting that measure and taking the 0 score for doing such.
All right. Carol, thank you so much for that question. Feel free to submit a follow-up or more information if we didn't get it all. Our next question is from James. If an EHR is certified, does that mean they'll be able to get me a file of performance for those eCQM measures? So what does it look like, I guess, to assess, the readiness of your EHR to perform this function?
Yeah. We work with a lot of EHRs. We work with a lot of certified EHRs. And you'll find that there's variability there. I think that in many cases, when people are looking at the eCQMs, they think, well, I'll just get some really easy QRDA files. And it really depends on what your member practice relationship is with the EHR, what they have purchased, what they've licensed. And it is, I don't want to say it's less about certification, because there is certainly a piece of that. But just because you have a certified system, that isn't necessarily a green light A+ that you're going to get the exact file that you need out of it.
Right. Great points. Yeah, the certification question also comes up frequently in groups that I'm talking to. And just to be clear, the EHR in question needs to have 2015 edition certification. Now, that certification has a whole bunch of different requirements. One of them is the ability to report these eCQMs. And what you may find is that all EHRs are not certified to report all measures. These are pretty common measures, so if they're going to be certified, most likely these are going to be the ones. But just because they're certified does not mean they're certified to report all of the measures at once, or all of the measures, all the 47 measures that Allison pointed out. Yeah, I think that's the key point. And the other point is they may be certified, but you may not actually have paid for the ability to see those reports. Some EHRs or EHRs that are certified don't necessarily just provide that as the base functionality. So that's something else to look at. And then once you've got that, it's really looking at the performance that those measures are producing, or the performance that they're showing you, and at least taking that initial gut reaction. It's like, are we doing well? Are we not doing well? If we're not doing well, is this real, or is this just the points that Allison was making around the standard workflows?
Yeah, great. Thank you so much for that question. Sort of in the same realm, but from a different angle here, we have a question from Mary. What advice would you have for engaging with clinicians and the member organizations and practices around documentation and workflows to make sure that you're getting the data you need to show that performance, the numerator in particular, but all the data is challenging, and sort of alignment across all those pieces. So Allison, that seems like a good one for you with your background and role.
Yeah, that's a really good question. So one of the things that we do here is when you have your assigned consultant, if you are providing us clinical data, which I would anticipate many of you guys would be, we also then assign a clinical informaticist to your team. So between the consultant and the clinical informaticist, right, we're going to be looking at exactly these issues. We're talking about workflow, we're talking about documentation, and making some decisions about how you want to engage with your clinicians. And so we can absolutely help with that. I think that one of the key challenges is going to be where can you engage the best? You want to have the biggest bang for your buck, right? So we'll look over all of your member practices and sort of decide, where would you like us to engage? We've got some different options. We can engage with you up here at the entity level. We also can help engage at the individual practice level. So if you need the consultant and that CI team member to connect with one of your member practices, or maybe with the hospital that's in with all of these other member practices, we'll figure out the best way, and that's part of our project plan, is to really key in on where our biggest bang for our buck is. Where can we make the biggest, best impact?
Great. Yeah, thank you for that question, Mary. Our next question here is from Jim. What does a timeline look like for an organization to get ready for the APP?
Great question, Jim. I actually had a prospect ask me this question just the other day. Of course, it depends on how complex your organization is, what kind of data acquisition or data collection process will work for you. Then the process itself is, we're actually usually fairly quick about onboarding a practice. It depends, again, like if you have a dozen member, or I'm talking to some groups that have 30 members and 30 different EHRs, and getting all of that data together and getting some kind of process in line is usually something that's going to take a month, 60 days, 90 days. Typically, one of the things that we do with our larger organizations, and ACOs usually would fall under that category, is we usually try and ask folks, or have folks think about spending about 90 days just getting getting ramped up prior to starting the program year. So you've got work that you are currently underway doing for the program that you're in right now, or the program year that you're working on. And particularly, as we know, at Mingle we call, the 5th quarter is actually reporting season, or when you actually have to collect all of that data. So trying to start a new program and finish up an old program year both at the same time is a lot of work and a lot of effort on both parts. So typically we look at, we can do it a lot faster if we need to, but typically what we ideally would want to do for you is, however you're planning on making the transition, that you really have a fairly solid plan that you're starting to execute about 90 days out.
Okay, that's great. Thanks for that question, for explaining that, Jeff. We have a question here from Veronica. I'm new to quality reporting and still learning about the APP. Where does CART, the CMS abstraction and reporting tool, fit in with these reporting methods?
So I can take a little bit of that. So yeah, CART is an abstraction and reporting tool that is an application really for the collection and analysis of quality improvement data. It's my understanding that it is available at no charge to hospitals and some other organizations, but that is really specific to the severe sepsis and septic shock clinical area. I am absolutely happy to dig into that a little bit more, just to try to give you a little bit further guidance on it.
Great. Thanks for that question, Veronica. We have another question here from Carol. How do you pull your denominator patients if we don't bill out of the same system as we document in, and sometimes use non-structured documentation in some cases? We're working in 4 different EHRs as well for 2022.
That is a great question.
This is the meat of this challenge in this transition. So I'll let you jump in, Jeff. Go ahead.
Yeah.
Actually, you know what I can do is I can go back to our data slide. But what Mingle has done, like I really mentioned, is that these challenges that are being faced as a result of the transition to APP are actually challenges that we have been working on and solving since the PQRS days, all the way back to our inception in 2012. And Carol, to answer your question specifically, what we will usually try and do, and what we do with the vast majority of our organizations, is to identify the population, the actual patients. We actually use claims data. And our preferred method is to collect your 837 or your X12 837 claims files. These are the files that you send to your payers. That's how you get paid. And the reason we use those is, one, they are a great source of data. They have everything that we need to identify a patient population, the patient demographics, the CPT codes, the ICD-10 codes, the providers, the dates of service, all of those things that we need to identify whether a patient qualifies for a measure or not are all in there. The second benefit to using them is everybody is already producing them. If you are submitting claims to a clearinghouse through your practice management system, you already have these files, and it's usually not a big deal to identify where they are and get them to Mingle. And then the last and final piece of the X12 837 files is everybody's using them. They have all the data we need. And that because they're billing files, they get a lot of attention, because if they're not right, they're not getting paid. So they're usually a great source, a very complete set of information.
Thank you guys so much for all of your questions. Charles, it looks like we're at about 5 minutes to the top. I would really like to encourage anyone who has further questions to reach out through our contact. It is our consultants, the kind of consultants you'd be assigned, that answer the chat and phone, and we try to get back really quickly.
Yeah, absolutely. Jeff, Allison, I want to thank you for sharing your knowledge and expertise with all of us, and everyone for joining us today. This was recorded, so we're going to send this out by email later this week, maybe even today, depending how quickly it comes out of the system. Please do reach out to us. Keep an eye on your emails from Mingle. We're going to be sharing additional resources and opportunities to engage with all these topics that are part of the end of web interface. We have some executive roundtables coming up, in fact, to sort of have a more collaborative space to understand what's working and what's, you know, a challenge for other folks in the healthcare environment. So be on the lookout. We want to be a resource to you. So thank you for joining us, and please be in touch if we can help in any way. We'll give you a few minutes back now, so enjoy the rest of your day. Thanks, everyone.
Thanks for joining us.
Thank you.